Mark, thanks for making out the trip. I do appreciate that you declined wearing a buffalo costume, but you at least made it here. So, so thanks for being here. We appreciate it.
Happy to be here. Ray, you going to fill me in on what the buffalo's about, though?
Yeah, I have a feeling we're going to get that question a lot. Well, the company name is torrentia, which is meant to come from a torrential downpour. And I think as rehabilitation professionals, regardless of where you fit into that, I think we can all agree that we're in a storm. And we want things to change. I think we don't necessarily feel like we have the power that we want. We're not able to achieve the outcomes that we necessarily want. Our hands are often tied. Reimbursement rates are dropping. And so, you could deal with a storm a couple different ways. The easy way to deal with a storm is you do what you're comfortable with. You do what you're used to. You just go into your standard operating procedure. And for most animals, that is to run as fast as possible away from the storm. But the reality is if you do it that way, then you're going to end up in the storm the longest. You're going to end up wet, and it's just not going to work out the way that you want. The buffalo is interesting because what we know about the buffalo is that it's the only animal in nature that deals with storms differently. In fact, when they feel the storm coming on, they actually face the storm and they run into it head on, because they know that the best way out is through the storm. And I think that's really what we're trying to instill in rehab in general, that I think there is a way that we can be better, that we can do more, that we can have a bigger impact on both clinicians and patients. But in order to do that, I think we have to face the storm. We have to think outside the box. We have to think about things in a more of a multimodal way, a multidisciplinary way, a way that is mutually respectful among professions so that we can really learn what works and what doesn't. And if we can start to have those conversations and provide that training, and we really go towards that storm in a way where we want to create massive change, I think we have the ability to do it. We just have to be the buffalo.
So where do you think we are right now? Are there a couple buffaloes in the field, or, is there a group that we're already working with, or where are we at?
I see a lot of buffaloes. There's a whole lot of people that fit into the world of rehab. And I think if you asked any of them, they would tell you they're a little bit disgruntled. They're overworked. They are seeing multiple patients an hour. They're just trying to make ends meet. Reimbursement is horrible. They don't necessarily have the conversations, or are not able to have the conversation about patients with other medical providers. And as a result, I think many of them, they just don't feel great about what they do because they're not able to have the impact that they want. And I think the point is that we want to be able to give people hope again and give them some inspiration that they can have that impact. And that there's a lot of different ways of doing that. But one of those ways is, to get good at the things that you're not really good at right now. And I think certainly part of that is starting to have the conversation about some of these advanced level technologies that come from your company, and teach people not only that they're great, but teach them how to use them in an optimal way. Because if we can do that, and if we can start to show our patients and our peers and our referral sources and our insurance companies that this stuff not only works, but how it works, and we can package it well with what we're already doing in order to get better outcomes, I think we had a shot at eventually starting to turn the tide on the storm and eventually become the standard of conservative care.
It's funny, I was having a conversation just yesterday with my wife. She's a physical therapist, owns a small pediatric practice. And she was talking about motivating her staff and what they needed. And I was giving her some of the stats on the burnout rates, that came out of the recent WebPT State of the Nation report. And, I think it was like 33% of therapists are burnt out right now.
Sure.
And I think in 2024, over 22% left their job. So, the question I posed to her, I said, what do you think is the motivation for young therapists or therapists in general, the fuel in their tank that keeps them going through the day? and we weren't on the same page. But that comment you just made sort of backs up what I was defending, which was to be great. If you're getting great outcomes with your patients every day, that's the fuel for the average therapist. It's not that they're getting some, sort of incentive or something like that. It's about knowing that they're making meaningful change in these people's lives and they're seeing it on a regular basis. And it's because of their input, their problem solving, their treatment techniques, the technology that they're applying, put that all together into the pot. And they're having regular people on a regular basis say, hey, you helped me a lot. Thanks. Would you agree with that? Or
100%. And in terms of, private practice owners, everybody wants to grow their practice and they want to be able to have a larger scope, be able to help more people, right? The best way to do that, Ben and I talk about this all the time, is we have to be able to get the skills to be able to see the patients that no one else can see right now. It's the specialty patients. It's the ones that are a dime a dozen, that are out there, that are suffering, that have given up on conservative care. They've been to this guy over here, 3 of these guys, a little bit of this, and they're resigned to live with headaches. They're resigned to live with pain during sex, whatever it is. And if you can open up the floodgates on those patients, bring those patients in the clinic and show that you can actually have that impact. Then we're talking about what's the next clinic we're going to open. And I just want people to see that that's possible.
Yeah. Over the past week, Mark, I think I've called you Mark Calloway, Mark Callahan, I think even Mark Calrissian at one point. So maybe just give us a little introduction with the correct enunciation of your name and who you are, why you're here, and maybe a little bit about life in the day of you.
Yeah. So thanks, Ben. Mark Callanen is, everybody wants to say Callahan, but it is Callanen, Irish descent, in the name when you look through the anthologies, but must have come over on the boat. Maybe they changed it, once upon a time. But anyway, I'm the director of clinical education for Enovis, and they are the parent company for Chattanooga, which is a device company that most clinicians are familiar with. They've been around for over 3/4 of a century now. We had our 75th anniversary, I think 2 or 3 years ago. So they've been around longer than most of us have been practicing, and they provide a number of different products that are beneficial to the therapeutic world. Enovis is a larger medical company, which is across surgical divisions, implants, things for foot and ankle. So the Chattanooga, the rehab side is just a small piece of a $2 billion market cap company. So we offer things that as Enovis that most medical device companies can't, just from a scope and scale due to our size. So a lot of times people get very nervous with like, hey, if I buy technology from this company, are they going to be around if this thing breaks in 2 years, or I need another upgrade or something 3 or 4 years from now, which is a legitimate concern. With our track record, we're not going anywhere, right? And when you look across the board, we're the largest rehab provider in the recovery sciences space. We're the number one high power laser in the world as far as number of people that are using it and have access to it. Just for support of laser and shockwave, for example, we have over 250 people in our company that are either engineers, customer service, medical educators, sales personnel, or different customer service type people that can help you if you have a problem. A lot of companies that you might be talking to have 10 or 15 people in their division, So just our ability to be there to help provide the information and help that often people need, especially if they're just getting into something and they're learning how to use it, or something happens unfortunately, if something were to break or go down, having a solution to be able to help that is great. So I'm really happy to be here with you guys to help, talk a little bit about how shockwave and laser and maybe some other things can help patients. And I think that's what brought us together as Enovis and you guys, is that we have a shared mission on trying to help the therapy world provide better care.
Awesome. So we're with Terentia. We're kind of talking about quite a few things, with laser and shockwave technologies. You got to hear some of those things. We talked a lot about dosage, right, in terms of lasers, and you seem to get asked that question a lot. Do you want to talk a little bit about maybe some of your stat pearls or some of your, input, in terms of dosage, and others maybe that we're not thinking about or that we could think about differently, or, I'll just kind of leave the open mic for you for that.
Yeah, I mean, there's a lot to unpack when you start talking about dose, right? And you guys know that well because you talk about it at great length with different things that you're bringing up with the courses. But I think I tell people often if you went to the doctor and you were a 300-pound individual and you said I have a headache and they gave you a baby aspirin, it probably wouldn't be very effective, just based on the morphology of that patient and the dose of that medicine. Whether it's exercise or shockwave or laser, it's no different. Dose is extremely important. And unfortunately, most people don't understand it real well. So it's important to, a big chunk of my day job is to make sure that our users and that people that are inquiring about this technology understand how that plays. Because if you miss on it, you can incorrectly make the conclusion that, oh, this technology isn't effective for the problem, when in reality, it might have just been that your application of the technology was not correct. So trying to clean that up and get that as correct as possible with our users is a big, important thing for me. With laser, the thing that's challenging is that there are a lot of variables. So as you'll hear in your guys' courses, wavelength is a variable. How bright the light is, the power or the power intensity, more specifically, the irradiance is important. The dose, the fluence, which is joules per centimeter squared. So how much energy are you putting in per unit of tissue? Those things all interplay, and they're not small things. So the nice thing is, our company has been around doing this since the early 2000s, figuring out how to do this initially in the vet space, and then eventually migrating towards treating humans. So class 4 lasers became available in the US around 2003 or so. That's when they were okayed by the FDA. The class 3B lasers, the lower power things, were around since about 86. So people might be familiar with that term cold laser, and that's something that goes along with those lower power devices, because when you put it on the tissue, they don't feel anything because the intensity of the light is such that it doesn't create any thermal pain. Sure. Class 4 devices are anything over a half a watt of power, and there is no class 5. So everything over a half a watt or 500 milliwatts is considered class 4, and those are enough that you'll put that on tissue and you'll feel warmth on that. So that's an important differentiator, and like you'll learn in the courses that you guys present, is that the higher power devices are very different in what they can do to tissue versus the lower power devices. And that's being shown in multiple studies that are putting them head to head for various conditions and showing, hey, they're not the same. Having a higher, brighter light, higher power is just impacts cells differently than when you put a lower power light on something. So it's important that, in addition to all the variables we just mentioned, the applicator is important too, right? So if the device you're using doesn't match up to maybe the specific study that you're learning about or the specific topic or course that you guys are providing, and they're going to try to maybe get by with something else, they may not get the same results depending on what they have in their hands. So that's an important piece for people to understand.
One of the things that, to that point, is we look at studies in vivo versus in vitro and kind of the application of the laser to maybe a petri dish or to a test tube, in terms of studies, or maybe it's an animal model or even a human model. Bray, do you want to maybe give just like a basic overview of the differences of those types of studies? And then Mark, I want to hear your thoughts on, okay, well, if we are talking about an in vitro study versus an in vivo study, what are some things we need to be careful of as we read through the literature? Because it's easy for the wrong conclusions to be made based on the wrong application of a study to a patient, when you're trying to have an intended effect and maybe your dosage doesn't match up. Maybe you're only using 5 joules per centimeter squared and you should be using more, 15. Maybe how can some of that be explained just from a literature standpoint?
Yeah, I talk about dosing a lot. Mainly because I get very frustrated when we visit clinics and I see a lot of clinicians, they just literally turn it on, whatever it is, and then everybody gets the same treatment. And I feel like we could be a lot better if we would really pay more attention to how to properly dose treatment. So in previous lectures, we really talked through how to properly dose a continuous beam, how to do a pulse beam, how to do it if you're going to move the laser. We talked through a bunch of different equations, but I really did love what you said. A lot of studies that you're going to read, even though we're going to be providing treatment in an in vivo way, a lot of studies are actually in vitro. And that's a really big deal, because you've got to be able to take those studies and apply it in an in vivo model by getting the dose right. And that's not necessarily an easy thing.
Hey, it's Bruce and Ben. We wanted to take a moment to welcome you to our YouTube channel, Terentia Medical Education.
Terentia was created for rehabilitation professionals of all kinds to really work together to start changing the way that healthcare is currently being practiced and what the future of healthcare looks like.
We hope that our content and community helps inspire you to be a part of the next level of clinicians that are going to treat our patients out in the world today.
Beyond just joining us in our free community that we call the Terentia Tribe, you can also check out some of our events on our events page at terentia.com. Each and every one of our orthobiological hacking conferences and events and future events to come is really designed to help you really master and learn these regenerative concepts, as well as take charge and move the rehabilitation profession forward.
We're really excited about the orthobiological hacker certification, and we have much more content coming. So subscribe, check out our YouTube, check out our website, join the community, and we hope to see you at our events.
And remember, a storm is coming.
Thanks so much for watching.